we can get started. This is one of 6 parts of the Healthy Brain Aging. And today we're going to have an interesting panel to discuss issues about care for the older adults and care for older adults with dementia. And I'm sure that you have many, many questions to ask based on your experience. First-hand experience for many of you, right? So we're going to introduce our panel who is really into caring issues. And I'm going to ask Janae to introduce our panel.
Hello, everyone. Thank you so much for attending. We are so thrilled to be back here with you all and seeing familiar faces. So thank you, Lenny, for the introduction there. We're really excited to have a panel today. So a little bit about the format, and then we'll launch into some individual introductions. The whole purpose of today is to hear questions from you all. So we're going to do our introductions, and then we'll open the floor where you can ask anything. There's no such thing as a bad question. And we have wonderful experts here at this table who will give you honest feedback, advice, and direction. So with that, maybe we'll start at the end of the table. We have a new face here, Dr. Devin Lavender. And do you mind introducing yourself and telling everyone a little bit about yourself?
Yeah, absolutely. So as Janae mentioned, my name is Devin Lavender. I'm a clinical assistant professor at the University of Georgia College of Pharmacy. And just a little bit about me, I actually practice pharmacy a couple of days a week at the VA clinic here a little north of Athens. And then I got involved with the care center through Lisa. We were working on another project together, and she forcefully pulled me in. But I really enjoyed it.
Nobody here will believe that.
But yeah, so really excited to be here and participate and hopefully provide you guys some answers to your questions.
So I'm back. I'm Dr. Don Scott. I was here about 6 weeks ago and gave a presentation. I'm an internal medicine physician and specialize in geriatric medicine. And let's see, I am a professor at the medical school here, and my main job these days is to teach medical students and residents, and I'm the medical director of the Care Clinic, which I know that you've heard a good deal about. I'm originally from far southern Illinois. I like to point that out, far southern Illinois, not from Chicago. So yeah, that's me.
Forcefully. None of these people believe you. No one here knows me and would think that. So hi everyone, it's good to see your faces for the 5th time during this seminar series. Thank you for hanging with us. We anticipated that our group would be slightly smaller and cozier today because this is questions and answers, and not everyone who has been learning about brain health with us has specific questions and answers about living with Alzheimer's disease and related dementias. So I'm a neuroscientist. I study brains and how brains change based on the things that we do to them. I am an associate professor and the incoming director of the Institute of Gerontology at the University of Georgia. I am absolutely delighted to see your faces. I just have to say that out loud. I'm going to turn the mic back over to Janae, but before I do, I would also like to point out another profoundly special human who is here with us today. Hannah Huff, please stand. That is Hannah. Yes, I approve of this. Let's do a round of applause for Hannah. So some of you have gotten to know Hannah fairly well. Hannah is the person at the Care Clinic who you will speak to first if you call. She is the person who will hear your voice, who will have a wonderful conversation with you about life, the universe, and everything. And yes, your health included in the everything. And we'll work to make sure that you're there with us in our clinic getting what you need. Hannah knows more about clinic operations than anyone in the world. She keeps us functioning. She is the reason that anything gets done there. So I thought it might be nice for everyone to actually get to see Hannah in the back in action. If Hannah ever leaves us, you'll hear us crying all the way from here. Janae.
Thank you so much. Hannah, since we put you on the spot, I'm wondering if you would mind handing the microphone to folks who might have questions.
Yes.
Thank you. And hi, everyone. I'm Janae here. And you heard from me last month. I'm an engineering psychologist. I was forcefully led to collaborate with Lisa. So Lisa and I both started at UGA in 2017, and she somehow got my name prior to us even starting and working together, and started harassing me with emails about how we're going to be best friends, and we're going to get wine, and we're going to do good research, and all of those things came true. So I'm an engineering psychologist by training, so I look at the design and implementation of technology for persons with dementia and their caregivers. I also have a joint appointment in the School of Social Work and work on a number of initiatives at the Care Center, building up our telehealth capability, but also working on caregiver support. So that's us and our varied expertise. And so now we would like to hand the floor to you all. So if you have a question, if you don't mind maybe raising your hand, Hannah, I can give you this microphone. And I'd like to also ask the panel to repeat the question. I know they're recording this, and they definitely will want to make sure to capture that. All right, so any kickoff questions? Of course, Lenny has a question.
This question is addressed to Don. If a family member is suspicious that their loved one may have dementia of different types, and usually the first sign is kind of failing memory, but that happens to everyone. What kind of clinical protocol and procedures do you go through when some patients come to you with that question?
Yeah, thanks very much. And so the question is, if a loved one suspects their family member may have a dementia, what do we do in terms of how do we diagnose that? And so the first thing we do, of course, is we take a history. And the history just means what kind of problems is the person having, and they can be varied. It can be anything from problems with memory, which can manifest themselves as repetitiousness, not being able to keep track of stories, telling the same stories over and over. So that would be an example of a memory problem. And there are many other kinds of problems that people with dementia can exhibit as well. And so personality change can be one. So someone becoming much more irritable or acting, very depressed when they've been, very joyful and not depressed at all throughout their whole life. Not remembering how to get to familiar places. So there are a number of symptoms people can exhibit. And so then what I would do is, I would ask a lot of questions and specifically try to find out how long has this been going on, and is it getting worse? Because that often is one of the most important features of people with dementia. It's not so much someone is fine one day and the next day they can't remember anything and they're putting their wallet in the refrigerator. I mean, dementia doesn't happen just all of a sudden like that. It's usually more of a gradual progression. And then what we do is we would do what we call a bedside neuropsychology or neuropsychology test. And some of you may have had those, or some of you may have heard them. But it's not the one that goes boy, television, woman. What was the other thing he said? Boy, I'm not supposed to say anything like that, I'm sorry. Yeah, so anyway, it's a test where you're asked to do certain things. So, copy this figure, do some memory questions. So it takes about 10 to 15 minutes. And then based on the results of that test, I either have a higher suspicion where I may send you on for more testing, or my suspicion may lower. If I still have a high suspicion, then what I'll do is I'll look for things that can affect memory, like medications, certain other diseases like thyroid disease. I might order a MRI to see if there's any evidence of old strokes or what we call microvascular disease. So once the diagnosis of dementia is made, you have to find out what's causing it, because dementia itself is not a diagnosis per se. Alzheimer's disease is a diagnosis that causes dementia. So that's the basic of it. Sometimes I'll send people on for more rigorous and lengthy testing of their cognitive abilities called neuropsychological testing. Some of you may be familiar with that. It takes anywhere from 2 to 3 hours, but it's just a lot of questions that look at all the different domains of cognitive function. But one of the things I always like to stress is what you don't want to have happen to you or a loved one is you get diagnosed with dementia, and that's the end of the day, and you get given some pills, and you never really find out what's causing it. You need to know what's causing it, not just, oh, well, you've got some memory problems and here are some pills. So that's my long-winded answer to your very excellent question. Anybody else?
I guess maybe this is for Kevin. In this great US of A, it seems that every physician likes to prescribe something or other. Pretty soon, we have so many medications piled up one on top of the other. And sometimes, I had the great experience of finding a physician who said less is better. And all of a sudden stopping some medications, and wow, some of the symptoms improved from just the layers of medication. One was fine, but when they got layered one on top of the other, pretty soon, I don't know if they reacted with one another or whatever it was, but I seem to like that philosophy. And for some reason, in the great USA, they prescribe and they prescribe and they prescribe. I don't know if that's an easy way to get the patient out of the office in 10 or 15 years to get them that patient. Pretty soon. So I happen to like less is better. So can you comment on that, please?
Yeah, sure, absolutely. So the statement was kind of about prescribing and how physicians can sometimes overprescribe medications. And then sometimes those medications interacting can cause even more issues than the original problem was causing itself. So my philosophy that I talk with my patients about is I try to manage your conditions with the fewest medications at the lowest doses possible. So at the VA clinic, I see a lot of diabetes care, hypertension, cholesterol, and several other disease states that are more chronic in nature. But my biggest philosophy is I try to keep you on the fewest medications possible at the lowest doses possible, because you're right. I mean, medications can have unintended side effects or adverse effects, and it's no fault of the physician that happens, but I think that being aware that that's a possibility is something that's really important. And as you age, some medications become less important for you to be on. And as you age, some medications that were safer for you when you were younger may not be quite as safe because of the changes that are happening in your body as you age. So, we take all of those things into account. Me especially when I'm looking at the medications, one, to make sure that there aren't any medications that are causing any potential side effects, especially when it comes to cognitive impairment. And then just making sure that all the medications play nice together. That's one thing that I really try to make sure of as well. So I agree wholeheartedly. That's my philosophy, because I feel that we can definitely get by with using a little bit less, but I will use what's necessary to control the condition. So if it takes 3 blood pressure medications to control your blood pressure, then that's what we'll do, because the effects of not controlling your blood pressure are worse than the side effects that may come along with medication. So it's a balance where it may take more medications to control, you know, Joe's blood pressure versus Sally's blood pressure. But I think that, you know, in general, my philosophy is the same as that.
Devin, I have a follow-up question. So at the Care Center, we work a lot with families and folks after they've come through for a diagnosis. And one thing that sometimes comes up for folks, if anyone is worried that they might be on too many medications, what do you suggest as steps that can be taken to remedy that?
So I think that there are a couple of things. One, polypharmacy is a really big problem. So I always recommend using one pharmacy to get all of your medications filled, because the pharmacists or pharmacists that work there are going to be more intimately aware of your conditions, your medications, your doses, than if you're going to 3 or 4 different pharmacies to fill different medications. So that's step one, and I think that that's a huge thing that can really cut down on drug interactions that happen, because if you fill medication A at a pharmacy and it interacts with medication B that you fill at another pharmacy, those 2 pharmacy systems aren't connected, and those pharmacists have no idea. So I think it's really important to fill all of your medications at one pharmacy, and then ask your pharmacist when you fill a new prescription, is this prescription okay to take with the other medications that I'm on? Does it interact? You know, always ask more questions. What are the side effects that I should expect? And then if you're still concerned, I would recommend reaching out to your primary care provider that you have, or your specialist that you see for conditions like cardiology or kidney, nephrology, those type physicians. So I think the key here is to always ask questions. Don't be afraid to ask questions, because it's really important for you guys to advocate for yourselves as well in those situations when it comes to medications.
I have a follow-up question.
And by the way, a follow-up to that, not a follow-up question, just a follow-up comment. Have you ever seen that person in the checkout line? That person is standing there. There's a line behind them, and that person is going, but the sale price was actually 58 cents. And the whole rest of the line is getting irritated. Be that person. So if you're at a lot of retail pharmacies see an incredible number of people, and there's pressure when you're standing in that line to pick up a medication to not ask the question that you need to ask because you're conscious of all the people who are waiting behind you. Be that person. Stick it out and ask the question and bear the wrath of those behind you, because it's your health. It's worth it.
So, Dr. Coon, I'll get to just 1 second. So I was going to try to keep my mouth shut because I can get on a soapbox about this for about an hour. So I'll tell you a story. So one of the reasons I'm in geriatrics is my father was a prominent attorney and circuit judge in our Southern Illinois community. And he developed Alzheimer's disease when he was in his later 70s. But he was a little bit of a hypochondriac as well, so even before that, you know, every year he would go up to the Mayo Clinic and want a whole, full physical and everything, and then he'd want to go to this specialist and that specialist, and he did all that. So he'd go to this specialist and he'd get 3 drugs there, and he'd go to another specialist and he got 2 drugs there, and then he would go somewhere else, and pretty soon, he was on 15 or 20 drugs, and pretty soon he was wandering uptown in our little community lost, and people would have to bring him home, and part of that was because of all the drugs he was on. So the person, in the medical, in the doctor world, the specialist, it's not a specialist, the person who's supposed to take care of that and work with you about and have the big picture, right, is your primary care physician. And you should go to your primary care physician if you're worried about the number of drugs you're on and interactions and stuff, and talk to them and say, do I really need to be on all this stuff? Are there interactions here? And, you know, if they don't have enough time to talk to you about that, then you might want to find a different primary care doctor, especially if you're 65 years of age or over. Because that's really who's supposed to have the big picture, right? About all the drugs you're on and what all these different specialists, if you have specialists, are supposed to be maybe giving you. So, yeah. So anyway, I'll stop with that. But I wanted to say just something from the doctor point of view. So.
I would like to follow up on this for both Don and Devin. We can easily say drug interaction is going to come through with something that we don't know what's happening. But I don't see physicians really testing for drug interaction. The other thing too is that I've gone away from a primary physician because he doesn't have time for me. And he has 8 minutes, and once you get into the room, you start inching out the door. I practically have to drag him back. But if I give him the list of medication that I have, I doubt that he has the knowledge of knowing what the interactions are. We all can say we need to think about interactions, and there certainly are some, but there's no hard data, and the practicing physicians or even pharmacists may not have the hard data to advise people about what to do and what not to do. So it's easy for gerontologists and geriatricians to talk, and pharmacists too, to talk about that, but when it comes to actual implementation, I find it sadly lacking.
If I might ask the next question.
Yes, answer my question, sir.
Right, so what I would say, you're absolutely right, that there is a great lack of knowledge, especially when it comes to multiple drug interactions, right? And there's a lack of knowledge even when it comes to single drug interactions. So like, does this drug interact with that drug, all right? So there's a lot more known about that, but it's still not as much as it should be. Then how does this drug interact with these 5 other drugs you're on? Nobody does those studies, right? And so the only way that a lot of these interactions get reported is either when they're developing the drug, when they find the drug interactions, or as the drug is given over time, they get reports from pharmacists, from doctors, whoever, that we're seeing these kinds of interactions. So what I would say is, to echo what someone else here said, is that you're your own best advocate when it comes to this. So let me just say about the primary care situation, I completely agree with you that in our healthcare system, it's often the case that if you have a family practice physician, the typical follow-up appointment for an adult is 15 minutes. And in internal medicine clinics, it's not a whole lot more than that. Now, you all are very, and I mean this in the nicest way, but in general, you all are a privileged group because most of you have a decent amount of finances, and please don't throw things at me, but you probably have, a decent amount of finance. There are things now, and you can argue about the ethics of it, but there are practices now that are called concierge medicine practices. And there are a couple here in Athens. And so for a certain amount of money per month, I'm in one, and in my case it's $80 per month, you go to a physician who sees many fewer patients, primary care doctor, because they charge this extra fee per month. So instead of having 2,000 patients, these physicians have more like 400 or 500 patients. Now, is it right that only people with money can get access to that kind of care? No, but it's how it is. And so, one of the things that I tell folks is if you can afford that kind of thing, you're going to have longer doctor appointments. You're going to have 24-hour access to that physician. So, but I don't know otherwise how you solve how the primary care, having lack of time issue works out. Now, having said that, there's something that I can send to you, Dr. Poon, or to whoever out here. It's called the Beers List, BEERS, and it has nothing to do with Chennai beer. and it has nothing to do with the alcoholic beverage, okay? It's named after a physician who was the originator of it, and it is a list of medicines classified in different ways that need to be thought twice about if you're over the age of 65, okay? And so it's organized not only by medicine, but it's organized by type of problem. So let's say you're having a problem with dizziness and falls. You can look on the Beers list under dizziness and falls and see the kind of medicines that could be contributing to that. So that's one thing. And you know, most of you, I'm sure, are perfectly able to Google things and look things up on the internet. So the other thing you can do is look for drug-drug interactions. I have an app on my phone that I can enter drugs into, and it will tell me the known interactions between those drugs. And Devin can speak to this, but the VA has a system, and most electronic medical records now have systems that for the known drug interactions, when I prescribe a drug and someone is already on a drug that may have a side effect, it'll give me an alert and a flag. So that's the, but I completely agree that there's not enough known about this.
Well, that's very, very useful. And I think if you could provide us the information I'll share with everyone here. But there's one other component that we have not talked about when it comes to interaction, and that's the individual. I mean, you can talk about drug-drug interaction, but drug-drug and the person interaction. And so for one person, that interaction is very minimal or none. For another, it is devastating. So I guess,
Like someone with dementia, for instance.
Yes.
That gets a drug that might not affect you at all, but it's going to knock them out.
that's right. And I think that's a very fruitful area of research, is that add the person into the picture.
Yeah, so just to follow up to all of that with a couple of points, to put you all at ease, what Dr. Scott was saying is that if anywhere you get your prescriptions filled, there is a drug interaction checker that automatically looks at any medication that they have in the system and runs it against that new medication. And the pharmacist has to review that and say, okay, is this an interaction that warrants an intervention? So kind of similar to what you were saying, it kind of depends. Some interactions are mild, some are more major that they need to intervene on. So that's first and foremost. Any prescription that you have filled at any pharmacy, there's a drug interaction checker that automatically runs, and it will alert the pharmacist if there's something that they need to intervene on. So peace of mind for that. Also peace of mind, exactly what Dr. Scott said, that anytime we enter an order into the computer in our electronic medical record for known drug interactions, it will automatically send a pop-up and let us know that that drug is an interaction. Because you guys know there are hundreds of thousands of different medications out there. It's impossible to know every single drug interaction that could possibly exist. But because of these electronic medical records and electronic resources, we have that at our fingertips and can really evaluate them critically and make a decision if something needs to be acted on. And then going to the entering the person into the discussion, I wholeheartedly agree, because that's kind of an up and coming area of research. People are getting their, like getting some genetic testing done to kind of see what parts of their body may not metabolize drugs as quick as the normal population or usual population. A lot of drugs are metabolized in the liver by hundreds of different enzymes, and each of those enzymes act at a different rate in every single person. So you can imagine that a lot of what we have is based off of what a usual person would react to and how they would metabolize it, but that doesn't mean that's everyone. So you're exactly right. One medication may have no side effects to one person, and then the next person takes it and it keeps them in bed for a week. So genetic testing is something that's kind of up and coming, and it gives us a really good idea of medications to maybe steer away from, or maybe use a lower dose if we know that you metabolize that a little bit slower, or vice versa. If you metabolize it a little bit faster, maybe we need to give you a higher dose. So that's all being looked into. Applications for it at this point are kind of limited, but it's something that is being worked on. Also, FYI there.
Dr. Scott, I have a question for you. How important is it for a person to find the correct physician? We know as we're aging, that there are some physicians who cannot answer questions about the aging population.
So the question is, what's the best way to find a physician, especially if you're older than 65? Let's say. Do you know where the age of 65 came from, by the way, as a marker for when old age began? Right, so it was originally from the Social Security system. So, you know, when Social Security benefits came about, when was that, 64, 65? Somewhere around in there that the Medicare was enacted. Well, Social Security may have been before that. Does anybody know when Social Security started? 30s? In the 30s? Does that sound right? Yeah. And so it started in the 30s. But where did they get that number? So in the 1890s in Germany, Germany was one of the first developed countries to have or to develop a social sort of safety net system and for older adults. And so at that time they said, well, what age do we want to pick that's, you know, a really old age and we won't have to throw that much money out, right? They picked 65 because, you know, how many people lived to 65 in 1890, right? Okay, now 65 is the new 40. Okay, so people ask me what is geriatrics, and I don't say it's people over 65 because, heck, most people, you know, a lot of people over 65 are completely healthy and doing fine. So anyway, if you just wanted to get that 65 number. And yeah, so in terms of, you know, finding a physician, if you can find a practicing geriatrician, that's, if you're 65 and relatively healthy, and don't ask me to define relatively healthy, but maybe you're taking less than 5 drugs and you have less than 3 chronic conditions, you don't need a geriatrician. You just need a good family practice doctor, a good general internal medicine doctor, right? So how do you find one of those? Well, it can be tough, and the best way I have found to find most things is through word of mouth, right? So who are your friends? Is there somebody who just raves about their physician? They spend a lot of time with me. You know, they're very sensitive. They listen to me, so on and so forth. That can be a very good way. If you can find a geriatrician and you have you're taking more than 8 medicines and you're starting to have functional or cognitive problems, finding a geriatrician might be a good idea. But guess how many people go into geriatrics? A lot, a medium amount, or a little? Even less than a little. So, right. Now, there are geriatricians in this town, and you know, one of the things I would ask when you call up for any doctor appointment is how long is your typical follow-up appointment? If I come in to see you for follow-up care, how long do you typically spend? And I'll say this for anybody over 65, if that answer is 10 minutes, then you might want to look for somebody else just because that's not enough time to see anybody. The other thing that you can do is that the 2 organizations that I'm a member of, the American Geriatric Society and the American College of Physicians, keep a list of physicians in your area. And so you can look that up, and I can send this information along as well about how you look into these organizations. But that is the best way I know of. The physician I see, right, is somebody that both I met at the medical school because he does some part-time teaching, but also I know just by looking at his training and by looking at the organizations he belongs to that he's a really great doc. And again, his practice is called direct primary care. He got fed up of being in a practice where he had to see, you know, 25 patients a day. So he and a colleague set up this practice where you pay him so much per month for the privilege of seeing them, and then your insurance will, it's complicated about how you basically have to take care and bill your own insurance. They give you receipts, but they don't deal with insurance. But anyway, so just so you know about this kind of a practice. And that's a really long-winded answer. I hope I provided some useful information.
So I have a follow-up question. Yeah. With our aging body, how reliable is the information we would get from a physician who is not a geriatrician, considering our body is aging?
I think that is a tough question. The easy answer is, of course, you wouldn't get as good information as you would from a geriatrician. That's easy for me to say. But again, I think that I would say that if you're 80 and over especially, that is really where the age-associated changes really start to happen and really start to be important. But again, someone who is a good family practice doctor or someone who's a good general internal medicine doctor, they know a lot of what I know. They know that they really have to watch out for polypharmacy and drug interactions. They know a good deal about how to assess somebody that's having falls and trying to help them. They know a decent amount about, dementia and Alzheimer's disease and those kinds of things. Depending on how much knowledge you have as, quote unquote, a consumer of medical care, then that can influence your ability to try to find the best physician. For instance, if you know that you can look up on the American Geriatric Society and find where the geriatricians are, or if you know that you can look them up on the internet and find out where they trained at, and you see somebody that trained at what sounds like a really good school to you, then they're likely, to be a better physician. But I want to turn this to Lisa just a second and ask specifically about the cognitive issues, about whether you think, Lisa, that most primary care doctors really know their way around the cognitive issues, and especially the difference between what is normal age-associated changes in cognition versus when do we have to start thinking about possible dementia?
So I have a short, cynical answer and a longer explanation. So the short, cynical answer is that there are actually data on this. So if you think of if you were to count every person in the United States who is eligible for Medicare, and then you were to say what percentage of those people go for an annual wellness visit. And that is supposed to be the moment that you sit down with your primary care doctor and you go through a very long list of items.
How many people here have ever heard of an annual wellness visit at Medicare?
Right.
I'm sorry, I thought we were going to get less than that.
Yeah.
Very highly educated crowd.
Yes. So if you looked at every single person who was eligible to receive Medicare, and you were to ask them, what percentage of you have had an annual wellness visit? It's about 50. So only about half of people who are eligible for Medicare actually go have this visit done. So you all know what it is, you've probably had it. So if we were to ask the question, what percentage of people who have the visit, now we're already starting at a deficit, right? We've knocked half the population who's eligible out. What percentage of you have had the cognitive screener? That drops down to about 30%. So I'd like to see it here. What percentage of you have had the cognitive screening portion? Smaller. Considerably smaller. That sort of represents the population too, except the folks who have had the cognition screening are 1% of 1%. So that tool in the Medicare annual wellness visit is supposed to be what your doctor would use to add a little bit of objectivity behind that moment when you go in and you say, I think I'm slowing down a little bit. I notice I'm not as sharp as I was. My wife says I'm repeating things. My husband says I'm not able to pay attention and follow things as much. I'd like to talk about this. That's the tool, the one that is supposed to happen for everybody who's Medicare eligible. So in the same study that looked at how little this is actually happening, the researchers asked why. Why isn't this going on? The majority of doctors who weren't doing the cognitive screening said it took too long. The rest of them said, I don't really know what to do with it. If I get that, I'm not sure what to say. So yes, your cognition has changed. Congratulations, you're older. Go ahead and feel everything that you want to feel about that. You're right. You're right to feel it.
And that is something at the care center we're very aware of and working on. So you'll hear more about this next month, but we are very active throughout the state. And interfacing with doctors, providing education is a major initiative of ours. We have heard from doctors, well, why bother diagnosing if there's nothing I can offer the individual who gets the diagnosis? And our response is that there are things that can be offered, and we're providing resources for that. So feel the feels. It's really hard to hear that data, but know that, you know, it is something that we are very passionately trying to address.
Yeah, if you were to, we actually did this in town. We did a surveying exercise where we went around to 3 specialty care practices: orthopedics, vascular, and a post-discharge medical clinic for people who are suffering from all kinds of complaints that should be answered with a surgical procedure. I won't say who the clinics were, but they're very, very large practices. And we sat in their waiting rooms with survey packets, and we asked patients, as waiting room time is dead time. You sit there and you're either listening to, you either know the politics of your physician because there's either Fox News or MSNBC on, or your politician goes, whatever, I'm Switzerland, have some HGTV. I'm not going there. But you sit there and it's dead time. It's a great time to get a little education if a practice would kind of think in that direction. But for us, it was good data collection time. So we hung out in waiting rooms at clinics all over town, and we asked people a lot of questions. First of all, we measured their health literacy, how confident people felt in being able to understand what their doctors were telling them and act on that information. And we measured to what extent shared decision-making was happening. How often do you sit down with your doctor and put your heads together about the solution that's best for you? And then we asked really basic questions like, how often does your doctor ask you about diet or exercise or all the lifestyle stuff you're going through? And the answer was, what? Diet and exercise? Really? No, that doesn't happen here. Sort of all over the place. So if you sort of think about the immense number of things a primary care provider or a specialist provider has to know and learn, it's impossible to learn everything, right? I mean, that's a really tall order, the sort of magically, perfectly versed physician who knows everything about your cognitive health and everything about your lifestyle. But it is telling that most doctors who were surveyed who were giving that screening say they don't know what to do with it. They don't feel comfortable with it. They're not sure what to do with the data. And it's similar with those lifestyle complaints. Like, I don't know what to tell you. You should probably eat good food. You know, so you brought up a very, very significant problem in healthcare, and that's one of the reasons that at CARE, our medical director, has helped us build an integrated care model where there's more than one type of practitioner, some of whom may have been forced into their responsibilities, who are around and able to pick up pieces of that, you know, of that experience, because it's a lot for any one physician to have to know.
So you may be wondering about, you know, cognitive screeners. Well, what is a cognitive screener? And there are a variety of them. The longest one that we typically use in office practice is called the Montreal Cognitive Assessment. It's abbreviated MOCA. And it takes about 15 minutes, okay? There's another one called the Mini Mental State Exam. It takes about 15 minutes. And there's another one called the MiniCog, MINI-COG, and it takes about 3 minutes. Now, it's not as good as the other two, but if you fail the MiniCog, okay, it is a really good indication that you probably have a significant cognitive / memory impairment. So here's how it works. I ask you to remember 3 objects: ball, penny, table. Can you all say those back to me? Yes, and it doesn't matter what order they are, okay? Okay, now I'm going to ask you to draw the face of a clock. I want you to draw the face of a clock just like you would see up on the wall and put all the numbers in, okay? So you do that. And now I say, I'd like you to set the hands of that clock at 10 minutes after 11. Okay, now you do that. Guess what the next thing I ask you is? What were those 3 words? If your loved one cannot remember any of those 3 words, the probability is very high they have significant cognitive impairment. It doesn't mean they have dementia necessarily, but they may have significant cognitive impairment. If you can remember all 3 words, it means you probably don't have significant cognitive impairment. If you remember only 1 or 2 of the words, then I look at the clock, or you look at the clock. If that clock looks good, all the numbers are where they're supposed to be, and the hands are pointing at 10 minutes after 11, you probably don't have significant cognitive impairment. If the clock is messed up, the numbers are not all there, they're not in the right order, the hands of the clock are not correct, then it means you may have significant cognitive impairment, okay? And again, I can send this to you. That test is so simple to do, any of you can do it on each other, right? I mean, the other 2 tests I mentioned takes training to know how to really do them correctly. But the easiest way to do it is have somebody remember 3 words. Give them 3 words, ask them to repeat them, have them draw that clock, set the hands at 10 minutes after 11, then ask them what the 3 words are. If they can't remember any of those 3 words, you should be worried. So it can be just that simple.
An interesting history of the clock, by the way, or I shouldn't say history, future look at the clock. Pretty soon we're going to have to retire it. So those of us who make these sorts of tasks, there's a neuropsychological task that I used to love called the direct assessment of functional status. And in that assessment, I would give people money and have them make change.
Nobody.
No one did, right? Or I would have them, there's drawing a clock on that one, there's mailing a letter, taking a telephone message. We would call on a fake phone and have the person take down a message. No one knows how to do that anymore. Congratulations, I think my generation, Gen X, will be the last group in history to be able to do those tasks. We're gonna have to come up with brand new tasks like take a selfie, check your Instagram.
What are we going to do about the clock draw, by the way? How many of you here know young people that don't know how to read an old-fashioned clock? Yeah. So I don't know what's going to happen with the clock draw, but I've asked some of my residents or medical students to draw a clock, and they make a square and they put 11:10. Yeah, I don't know what's going to happen. I don't know what's going to happen with the clock. Do we have more questions?
So you've gone through all this, and the diagnosis is Alzheimer's, and you've been given the folders.
A little louder.
You've been given the diagnosis of Alzheimer's after all the tests, not me personally, but maybe. And you've been given all the pamphlets on the Alzheimer's Center, blah, blah, blah. And you go home with your loved one, I guess you should call them LOs. And there you are. You're home with your loved one who has Alzheimer's. And there's a caregivers group, and there you are. What then? Do you just wait until they're so ill that they have to go into care while you struggle along daily dealing with this? What then is my question. And I think a lot of people are there. Okay, he's got it. What now? That's my question. And I love the care center, y'all are fabulous, but what now?
Yeah, so the question is, you receive the diagnosis, and then what? What supports are out there for families to deal with this? And that's something we think about a lot at the care center. The last thing we want to do is provide a diagnosis and say best of luck, right? So we address it in a number of different ways, and it varies, from family to family in terms of what might be the most effective. For some families, for some caregivers, education can help. Just kind of knowing the unknown, learning about how to manage problem behaviors. That knowledge can go a long way in feeling empowerment. and knowing how to interact with the loved one during behavior episodes. There's also the emotional component. Last month when I was talking with you all, we talked a bit about how you deal with behaviors. There's addressing physical components, but also emotional components. So finding ways to take that moment as a way to connect with your loved one. It may not work every time, but rethinking that relationship, that way to have a conversation, bring emotions down and reconnect. We've heard from a number of caregivers at the care center that while caring for their loved one has been one of the most awful things that they've had to do, it's also been one of the most beautiful moments where they can reconnect with their loved ones. And so to whatever degree we can help people manage those emotions, we do. That can be done through caregiver support groups, often connecting with others who are going through the same things that you all are can really help. Trying to think of anything else.
Yeah, so that moment when you get home it's a bad day. It is, and that is the understatement of the century. People feel a lot of different things when they hear a diagnosis for themselves or for a loved one. For some people, they turn into problem solvers and say, okay, I get it, this is a problem. Battle stations, everyone, let's figure out how to start getting through our days. For some people, it is, we've seen the head in the sand reaction, which is, well, let's just sort of pretend that didn't happen and keep going. For some people, we see grief. For some people, we see anger. There is no right or wrong way to feel. Numbness is, in fact, a perfectly legitimate way to feel. Give your brain time to process that. And that is for folks who are receiving the diagnosis and family members, because you're going to be doing this as a team. So in the sort of mental checklist of things to do, step one is to examine your daily routine. If it's working, keep it. It's a matter of saying, okay, I know we have a different title on what we are, on what's going on. We know what it is now. But our day-to-day lives can be what they are. You think about your routine, you think about whether or not it's working for you. You start making reasonable adjustments if you can. And for a little chunk of each day, you start doing some planning. Okay, so one thing that a lot of you have now, and that we are delighted to send to any of you as our guide, it's okay, let's tackle a few more pieces of our checkbox. It's setting aside time in your day to be together as a family. One thing that tends to happen if you're caring for a loved one is that the nature of your relationship changes a bit. You're used to having your partner in crime, a person who you jointly make decisions with. You still do, but it looks a little different, and it can become a little hierarchical with sort of me telling you, it's time for you to do this, it's time for you to do that. So finding space and activities that you can do that put you on equal footing, so that it's not you demanding that your loved one is doing something, can really help so that you still have that time together. Maybe it's music, maybe it's watching a show together, maybe it's going for a walk, whatever the activity is that makes you feel connected and not hierarchical. I'm telling you what to do. Those activities, identifying those are useful as you're kind of working through that checklist of we need to tell these people, we need to do this thing. And then for those of you who have received a diagnosis, and for those of you who are caring for a loved one, taking time out of your day, and if you need to have if your loved one is content watching a show or doing something like that, that's a really good time for you to sneak away and take a few minutes to yourself, because it takes time to process all of this. You go home and you feel like life just changed radically. But it's another day, one day that followed a day before where you didn't have a diagnosis. Take little moments of time to think about it and process and exist with it, because it's a lot of adaptation to kind of, once you have a name for something, you have to own it, you have to feel it, you have to live with it. So getting little tiny moments for yourself to do that help a lot. Otherwise, it's, Janae I know has more practical suggestions. Again, there's a to-do list of items to tackle together, but it doesn't have to be done all at once. You can take space to do them as you need to.
And I think as you're taking that space, identifying your care team. I think a lot of folks have an idea of a care team being, this is my doctor, these are my specialists, but your care team should be so much more. Who are your family members that you can lean on? Who are your friends? And really thinking through, okay, I'm going to need some help, and it's okay to ask for help. And how do I build the supports I need? One thing we see a lot is that caregivers don't necessarily take care of themselves. And if you're in a position where you're unable, to give your best because you're so exhausted, that's a good sign that a break is needed. And you have friends and family that will step in and help as needed. So thinking through that care team and knowing you're not alone can really go a long way for your own health as a caregiver, but also for your loved one.
Yeah, and the nice thing about a care team is joint problem solving. Right, so the problems that you have to solve as a duo are big. They're big. They're very big problems. It's estate planning. It's powers of attorney and healthcare. These are big things that none of us want to solve on a good day. So it's a matter of finding those people who are, and they don't have to be family. There's sort of biological family, and then there's logical family. Form a logical family here if you don't have the biological family with you who will help carry that load. Janae is my logical family. If you read my text to Janae, I'd be horrified. We are all caretakers in our life, and every time I have a caretaking issue that I want to run past, I say it to Janae. And she hears all the things. So find your logical family, that group of people who you can call and say, I've got to get some laundry done. Can someone please give me a lift here? Or I would like to go to the grocery store alone and just take a minute to let it all out my ears. Anyone want to come? Start a group thread here of people who can support each other and do it, support each other. A group of folks who go take a walk together, a group of folks who jointly grocery shop, who collectively solve problems. That's your care team. They're also caring for you. Just pay it back. When they need you, be there for them. And then it's a wonderful no-guilt situation. And there's wonderful practical problem-solving tips that way. You'll find what works for some, and that might also work for you. And maybe you'll share a laugh together. That helps.
Yes, sir.
This is more of an observation. My wife has had, I've said this to this group before, my wife has had Alzheimer's for now 15 years. I can assure you it does wear you out, and don't think you're tougher than the disease. One of the things that I always get frequent disappointments with is read the Wall Street Journal and a new drug has come out for Alzheimer's and it's going to cure everything. And then pretty soon another newspaper, another research. And so far, those articles have been a total failure. I think I'm correct in saying that.
You are.
There are a few medicines. This disease started in 1900 by a man by the name of Alzheimer's, identifying it anyway. It didn't start at that point, but he's the one that identified it. And I just kind of tell you all, there's no magic to this, there's no trick to it, it's a hard, roll up your sleeve job. But above all, I think the most important thing I could tell you that have not shared long periods is that you must have patience. You can't argue with them, you can't debate with them. And there's tricks to the trade that people can help you with to do that, to handle that. Don't try to do it because you're going to fail. And it also can be a lot of fun. I give you the sad part of it, but it can be a lot of fun. My wife now, who is here, makes no sense at all. But we go and we laugh together and we have fun together. We always kiss each other and say hi. Glad to be here. We've been married 65 years. And we have a mini romance there while she's happy with that, and that works out just fine. But there's no tricks to it. Just roll up your sleeves, and this kind of help I wish I had it 15 years ago. Thank you.
And Hal knows what he's talking about. You can always, I'm volunteering Hal to bounce ideas off of when you need to, because Hal knows what he's talking about.
And I think that, and I was thinking about your question also, and I was trying to envision right now, if my wife, I'm 62, she's 55, but if, she developed Alzheimer's disease, and it was me, I would know everything I'm supposed to do, every list, every this, every that. I know all that stuff. But that doesn't say anything about the emotion that I would have to deal with. And yeah, so now what? So now I'm home, I'm alone with my wife, and she's not the person that she used to be anymore. And that's going to just continue. She will become less of the person that I used to know. And I would just need some outlet for that. And the outlet would be, whatever has maybe worked for me in the past, whether that is a priest, a rabbi, a pastor, somebody, you gotta have somebody to talk to, and for many people, the support groups can function that way, but many other people aren't group people. They don't want to go to groups. That's just not who they are. But you have to find somebody you can process this stuff with and vent with and cry with. And I think that's one of the most important things. I mean, that's already been said, but I just wanted to say that. And the other thing I wanted to say real quick, sir, in regard to your comment, is that life does not end when someone has Alzheimer's disease, even if they've had it for 15 years. There are still moments of connection and happy moments. There can be for many people. That's not to minimize how tough and dreadful it is in other ways. But, life doesn't end, and there could still be a lot of meaning. But I'm not here to tell you anything because, you've been dealing with it for 15 years. So.
And for those of you who have a diagnosis, I think, it's a very different experience to hear all of this and think of what, of what you are very much part of your care team and the most active, right? So I think for those of you who have a diagnosis who are hearing this, it is, life does not end with a diagnosis. I mean, we built our entire center with the idea that we need to focus on living with Alzheimer's disease. There is still very much a lot of quite wonderful life to be had.
I'd like to ask if there are any daycare centers in Athens for the Alzheimer dementia patient, for those who are not ready to move them to our memory care.
Yes, Adult Day Health is an extraordinary resource. In Adult Day Health, for the person who is attending Adult Day Health programming, there's almost always food there. There are other individuals to speak to spend time with. There are things to do. There's art, there's enrichment, there's lots of wonderful reasons to go to Adult Day Health if you have the diagnosis. If you are a care partner, Adult Day Health is a great venue to both ensure wonderful social stimulation for your loved one who has the disease and be able to take a few moments to get some of those necessary tasks done so that when your loved one is back home with you, you have more quality time together. The Athens Community Council on Aging here in Athens actually has a wonderful Adult Day Health program. In most, I won't say most, but in many communities in our state, there are Adult Day Health programs available. There are in Oconee, there is a fantastic senior center. I mean, it's a wonderful, wonderful place. So there are places to go, absolutely, to utilize those services. And I know that in my house we were a little bit reluctant to send my grandmother to Adult Day Health because it felt like I'm the only person in the world who knows how to do this, right? I'm going to take her and something's going to happen, and I'm not there to solve it, and I'm the only one who understands, and that was silliness, because I'm not, right? When you utilize those services, you get enough distance that you see how much usually the person who's attending the adult day health facility actually loves it. So please, it's a process to surrender the guilt of feeling like I'm leaving a loved one here, I'm abandoning a person. I mean, this could not be farther from the truth. They are enriching, wonderful facilities, staffed with new human beings that your loved one can make a connection with, and that's valuable.
Sir, did you have a question?
It wasn't quite a question. I'm a past Alzheimer's caregiver, and I can tell that you dearly love your wife, as I did. And it's being a caregiver of somebody in Alzheimer's is probably the hardest thing you can ever imagine doing, and I apologize.
And this is why you form a community, because you know what Hal is going through. And it's, these sorts of connections that you all have together. I mean, you are here in a place where you can connect and be there for each other. It is so important to do. And I heard you say past Alzheimer's caregiver.
That's right.
There are, grief processing takes a very long time, and also is a good joint task for a care team.
It's forever.
Thank you for that.
Yeah, every question brings more questions to mind. Some of us have got more specific questions, which perhaps isn't appropriate for a group exposure. But when do we come to you?
I'm going to start on that one. So let me go ahead and say one other thing. That if you've had some questions answered today, as you ponder on it, as you stew over it, if more come up on Thursday, July 7th at 1:00 p.m., this team on the stage right here is going to, plus a few more, are going to reassemble in Hudson Hall at the Institute of Gerontology for another Q&A session for folks who are using who are involved in care and using care services. We're going to do this again. I invite all of you who have more questions to ask to please come out. You can also email us anytime at carecenter@uga.edu. Hannah will reply. Those questions, if they're specific, can come to one of us and we can answer them for you. When to see us is a great question. We see two types of groups at the care center. One type of family that we see are people who believe there might be something going on, but don't have a diagnosis. Right? So if you're hearing this and you're going, this sounds a little like someone I know, or this sounds a little like me, I should get checked out, then we would see you and do that. You'd start with a medical exam that is not 10 minutes. It's considered, if you were to email Don and ask him how long his exams are, I can tell you they're very long. Often we're going, you're in there? Okay. So they're long. We will take care of the medical piece first. If it is needed, it is not always, then we move on to neuropsychological assessment, in which case we would schedule a second visit for you, either with someone in town who can do it, or with our clinical psychology students who are learning how to do those assessments. You'll meet with them. We will generate a report. If Don believes that an MRI is necessary, he'll make those referrals. We get everything together, and then we'll bring you back to have a conversation about what it is and what it all means. So that's one type of person that we see. On the other side, we have some folks who have a diagnosis or have a loved one with a diagnosis and are requesting support. So they would like to sit down and go through care guides. They might need a referral for some other services. They're wondering what's going on with their medications and just are looking for another opinion. They are, would like to join a support group, which we have starting up in fall, right? So even if you're not seeking a diagnosis but need those other services, we're here for you too. So in either of those cases, that's when you should see us. But if you suspect that a problem might be brewing, very often you meet with Don and Don says, "You're all good. Don't worry about it. We'll see you at some other point in the future." So, so it's, the point is we will see you under either of those circumstances.
Hello. I just want to add one thing to that. So right now, we do not have full-time medical staff at the care clinic, okay? So I teach in the medical school, I teach in the residency program, and I work at the care clinic. So, some of you may have experience with trying to get an appointment at a doctor's office and they tell you it's going to be 6 months, or they tell you it's going to be 9 months. We will not tell you that at the care clinic, but it may be a couple of months. Because right now, I am not full-time every day seeing patients at the care clinic. But we will be happy to evaluate you as soon as we can. And our waiting lists are not as long as the typical neurologist or, another kind of provider you might find in the community. So, but I do want you to realize that there will be a bit of a wait if you do call us up for a medical evaluation. But it won't be 6 months. Hello. I have a question from my friend Devin here, who has been sitting patiently. Are you still awake, Devin? Okay. And I'm going to put Devin on the spot, because I really, number one, I'd like to hear his answer to this, and you all might like to hear it too. And then I would just like to ask you, are there effective medications for the treatment of Alzheimer's disease? Sorry, Devin. Let me take one thing real quick. Let me take one thing before I turn it over. You all may have heard there's a new FDA-approved drug. It's an intravenous drug for Alzheimer's disease. It does not work. It is no good. I would never prescribe it. It costs $56,000 a year, and 25% of people it causes brain swelling. So, okay, it's called Adumaticab or Adubabacab, or I don't know, I can't remember the exact name.
Aduhelm.
What is it?
Aduhelm.
Aduhelm, okay.
But yes, it's aducanumab.
So, and if I was going to be politically correct, I would just tell you it's highly controversial whether that drug is any good or not. So having said that.
Well, so I think the gentleman in the back kind of already put out there that there have been a lot of news articles touting medications that they're studying that show promise in the treatment of or reversal of Alzheimer's, and to this point, none of them have shown benefit. There was some thought about this new medication that it would be beneficial, but I agree with Dr. Scott's evaluation that the risks far outweigh the benefits of that medication, in my opinion. I mean, there are a couple of medications that can maybe help slow progression of memory loss, maybe a little bit better than a placebo or nothing at all. But there's nothing that treats Alzheimer's in and of itself. There's nothing that will prevent it outside of diet, lifestyle, making sure that you're treating other diseases that can sometimes cause and lead to Alzheimer's and other dementias. So unfortunately, the answer is no. I'm very hopeful that, as more research and as this issue is really continuing to rise to the forefront, that there will be something in the future that can prevent the progression, or at least delay the progression. But at this point, the only things that are out there are really meant to slow the decline of memory loss.
I have a question. When you watch TV at night, you can't go through all the advertisement and the drugs are out there, and the people think that that's going to cure them, so they go to their doctor and they put pressure on the doctor. But yet alone, other drugs, can't get approved. Now, how do these drugs that really maybe don't, really work, does the FDA approve those and then put those on the market, or how does this work? Or I can tell you, being a hospital administrator, I swear, I shouldn't say that, but I've had doctors that have come to me and wanted me to do certain things because they're in some study. And they're prescribing that to their people, and then they come back to me and the hospital and say, well, this is an issue, and stuff like that. I can't deal with it. I'm not a doctor. You have to go through the medical staff or whatever. But how does this work with the FDA letting all that stuff on there if it doesn't work?
So I'm going to let Devin answer this question, but because I feel extremely strongly about this, I'm going to say a couple of things. There have been snake oil and snake oil salesmen forever, right? Dr. Carter's little liver pills, and I've got a book. It's called One for a Man, Two for a Horse. I got these kind of books. Okay. And so the most widely advertised of the kind of thing you're talking about is Prevagen. Okay, I bet you've all seen commercials for Prevagen. There's no evidence that Prevagen does everything. I'll let Devin tell you why these drugs can be marketed and sold. But let me say one thing. If you have a physician who is trying to enroll you in any kind of a study, the next question you should get asked is, are you being paid to enroll me in this study? Because there are a lot of drug companies, and you think that this, should be illegal or something, but it's not. There are a lot of drug companies that pay physicians to enroll people in studies, okay, and that's called a conflict of interest. If I get paid a lot to enroll you in this study to give you some drug, I don't think that's right, but, it's a debatable thing, but anyway, so, here you go.
So to kind of answer your question about how these drugs get on the market if they don't really show any promise. So there are certain conditions that the FDA kind of views as special conditions or rare or orphan conditions. Alzheimer's isn't one, but it's because there are so few treatments available for Alzheimer's. Even if a medication shows potential promise, which that's kind of what they saw with this Aduhelm, they were able to fast track it and basically, I wouldn't say skip, but kind of skip the last part of the clinical trial. So they brought it to market with the caveat that when they bring it to market, they're going to continue to do extra reporting of adverse events and things like that to the FDA, and then after a set amount of time, the FDA is going to re-review the results that they see from this medication and decide should it continue to be on the market or not. So in the case of Aduhelm, that's kind of where it fits. So it was fast-tracked because there are so few treatments for Alzheimer's. It showed mild benefit, but again, you have to weigh the risks versus the benefit, and in this case, I don't think it's really worth it. Now, Prevagen, things are really tricky when it comes to over-the-counter medications, right? So the statements that are on those commercials about supplements aren't evaluated by the FDA. Those supplements usually aren't put through any sort of randomized clinical trial. Who even knows what those supplements contain? Because the drug companies or the people that produce them don't have to show that what they say is in there is actually in there. So in general, I say always talk to your providers about things like that, especially supplements. But for supplements that I would feel comfortable people using if they have a USP seal on them, so United States Pharmacopoeia, they are a group that certifies purity and potency standards of over-the-counter medications. But those are few and far between. We're talking like vitamin D, fish oil, maybe. So those are very few and far between. So it's difficult to say, don't take anything over the counter that's a supplement, but the statements that are put out there aren't really rigorously evaluated by any sort of governing body that can say, yes, this is true, or no, this isn't. And you'll probably also notice when they talk about Prevagen, for example, they don't mention dementia, right? They can't mention specific diseases because that's against the rules. But they say memory. It can help improve your memory or slow your memory loss. So it's very crafty with how they word those things because they can't say specifically, it will help you with your Alzheimer's, it will help you with your dementia. They have to kind of word it in a roundabout way because nothing that they're saying has been proven to treat anything.
And I was just going to say that, there are plenty of unscrupulous doctors out there. So, if Dr. Scott wanted to come up with Dr. Scott's miracle memory pills, and it's got ginkgo and B12 and vitamin D and eye of frog and root of snake, and that's all really good for you. So those are supplements. I can market that. I can say, in my experience, it improves memory tremendously, right? So, and not to be political again, but we do have one of those kind of doctors running for Senate right now. So I'm sorry, I apologize.
So a lot of that is if I wanted to start up and say I have a supplement and have a good person that can market this and put it on TV, I can make money, I guess, right?
With under these restrictions, as long as you don't say it cures cancer, if you just say, oh, it helps rejuvenate, right? And let me just say, man, how many drugs are there out there that are virility pills? It's going to help you with virility, right?
So let me offer a slight counter before we all burn our supplements. Is that some dietary supplements are actually studied rigorously. So for example, there's a massive, gosh, we're talking now probably about $30 million spent on it, trial by the National Eye Institute called the ARIDS trial, age-related eye disease. And in the ARIDS trial, they studied a formulation, an over-the-counter supplement manufactured by Bausch & Lomb. They studied, now we're at the second phase of it has just ended because the formulation needed to be changed based on the first study. Questions should be raised about the relationships between federal government and one private company, but not others. I mean, there's some shade, there's a little bit of suspect ethics, I think, in that respect. But the formulation has been studied in the most rigorous clinical methodology that you can do, and it's effective. There are other, instead of supplement combinations, like Prevagen, individual molecules have occasionally been studied. So for example, I've done research myself on just isolated, purified lutein and looked at brain change and things like that as a result of it. So, I mean, I can say that about the molecule, but not necessarily a formulation of the stuff. So, definitely caveat emptor, buyer beware. There are some really bad actors giving dietary supplements a really bad name, but that doesn't actually mean that they're all bad.
Yeah, let me just be clear. I don't mean that all supplements are bad, but
Prevagen.
But yeah, Prevagen, right. I mean, if you've got B12 deficiency, you need B12. And if you've got macular degeneration, this stuff that Lisa's talking about is great. So I don't want to give the wrong message about that. Did you want to say something, Jim?
Are you?
I'm
You're done. You never know with Tom. One thing we recommend when we work with families in terms of medication management, we say create a list of medications, but we stress include supplements over the counter and talk to your pharmacists and doctors about those as well. Often when you think of your medication list, you think of just prescriptions, so update your lists. I think we have time for maybe one more question.
I just have one statement. My internal physician told me when I showed him the supplements that I was taking that I could get rid of all of it too. And I had about 12. And he said, why are you taking all of it?
And the statement was, I'm not too good at this microphone. The statement was, I'm not too good at this microphone. So the statement was, I'm sorry, ma'am, what's your name? Marie Poon was saying that her physician was eliminated all but 2 of her supplements because they didn't seem to be necessary. I had a patient that came and saw me, and this is in, when I was practicing full-time geriatrics, that came and saw me and literally had 10 supplements he was taking. And, you know, we talked about who knows with prescription medicines, when you mix them all together, what happens. Who knows with all these supplements, when you mix them together, how they interact with each other and how they interact with prescription medicines. So you just have to be careful. The idea of I could get Alzheimer's disease is incredibly frightening. The idea that I could get cancer, I have cancer, is terrible. The idea that I have rheumatoid arthritis and I'm hurting every day is terrible. And there are lots of people out there that take advantage of that and sell snake oil. But having said that, there are supplements that are beneficial.
Well, and
We should just leave.
I know, but we are, they're big enough. So the other thing to say about that, though, is that keeping up on the literature on nutrition and dietary supplements is a full-time job. Most physicians, in my experience, I will always exclude the esteemed Dr. Scott, have not read the literature and are not up to date on it. So if they're saying, well, this isn't going to help you at all, it doesn't necessarily mean that they're not making a snap judgment at that moment rather than consulting the literature before telling you about it. So one thing you should be at liberty to ask your physician is, can you please do a literature search? I'll be doing one too. Let's meet back up together and talk about what the data look like. Because that's a lot of work to keep up to date on all of those things. Sometimes, you know, a conservative approach when you don't have much time in the room is just to say, get rid of it all, when there actually might be data for some of it. I have to be devil's advocate.
Can I go back to the Alzheimer's drugs just for a moment? The two drugs that were being used at the time to slow the progression was, if I recall, Aricept and Namenda. Are they still being used?
Yes.
I did notice a change when she went on them. Eventually, my VA rep, we were both ex-military, recommended that I seek admission for her at the Georgia War Veterans Home. And Jane, and I'm going to use her name, I'm very proud of it. She had been an Air Force nurse. She knew what she had, and she knew what the end result was going to be before it got to the point where she couldn't understand anything. That did come, and always will. But about halfway through her stay at the Georgia War Veterans Home, I don't remember if it was Aricept or Namenda, but they came out with a higher potency of it that her doctor there recommended. And almost overnight, that made a good change for the positive, but it only lasted a short period of time. I asked at one point, and I don't know, and I would be very careful to criticize anything that the doctor had said or recommended, but I asked, at this point, she doesn't know me, she just knows I'm somebody familiar to her. At the time, she had been the longest resident they'd ever had there with Alzheimer's. I think the nurses took a real liking to her because they knew she had been a nurse. And they kept her up around the nurses' station most of the time when she was able to. And I asked the doctor, I said, at this point, if Aricept and Namenda is no longer doing any good, should we just quit feeding chemicals? And he said, I don't think it's good to make that change. So I don't know if that was right or wrong. But at any rate, she survived with good care there for just over 6 years. And that was after I had done all that I was able to for several years.
If you don't mind me asking, how long did she live after she was diagnosed?
She was diagnosed with early onset and diagnosed incorrectly. I had not retired yet from the Navy. We were still at my last duty station in New Orleans. And strange things were happening, and she went without telling me what she was experiencing. went to her doctor who recommended a neurologist. And the neurologist there in Slidell, it was at a point where he wanted to recommend that she go see the big guys at LSU. And after they did all their MRIs and tests, for all who watched House, it was much like that at the end. We went in for the final visit and sat around this big round table, the doctor with all of his minions, and we discussed all this. They discussed it. And they weren't real sure, but they came up with, she's too young for Alzheimer's, so she must have MS. So they put her on a regimentation for MS, which lasted about a year. I retired, we moved to Florida. The military doctor at NAS Jax told me, I think it's probably Alzheimer's, but continue with this since you're going to Georgia. And we came back here, and I won't give his name, but a very well-renowned neurologist didn't want to believe anything I had to say to him. I mean, he was just, his bow tie and personality and all that is all he wanted to be. And he kept her on the MS drugs. Finally, I pressed him, and I pressed him, and I pressed him after multiple visits. And he said, okay, I'm going to send you to a doctor who sees for Alzheimer's or dementia. And we went there, and he said, Jane and Jim, he says, nobody knows for sure without going in and taking some of a load, and I don't want to do that. And I said, you're right. And he says, you've got Alzheimer's. So he changed the medication, and he weaned her off the MS drugs and started her on Aricept and Namenda. And that did help. And then she had hip surgery, one knee surgery, and had the next knee surgery, and I begged them to give her a local and listen to her, because she's going to make a lot of noise, but listen to her. And they would, because she has Alzheimer's, and they would not do that. They gave her the normal. And it had gotten to the point where, I don't know if they over-medicated or it was just a disease. It's beyond my realm of understanding about that. But she spent an extra day in recovery, just trying to wake up and be normal again. And after that surgery, it was a rapid slide downhill.
Thank you very much for sharing that story. There's about 10 things you said that I could comment on. But one of them is that up to 10% of all Alzheimer's cases are diagnosed before the age of 60. And so you don't have to be 80 years old to have Alzheimer's, of course, as you know very well. And the second thing I wanted to say was about the drugs. So there are 4 drugs that have shown beneficial effects. They can help a little bit for a relatively short amount of time. Some people they can help more than others, other people they don't help at all. And the 4 drugs are Exelon, Razidine, Aricept, and Namenda. Namenda is a completely different kind of drug than the other 3. But if my mother had Alzheimer's disease, would I want her to be on those drugs? Yes, I would, even if they only help a little bit. And in studies, they only show help, a little bit of help for a short period of time. However, having said that, in terms of pharmacology, that's all we have. Now, the issue of how long people need to be on it kind of depends on how much it helps. I mean, that's a complicated question. There's no study evidence where they've looked longer than 3 years. But, so I don't want anyone here to go away thinking that there are no medications that can help, because there are. There are medications that can help. But they help a little bit, and we're not really certain for how long they help. And what I typically do when I see people getting worse, especially if they start really getting advanced Alzheimer's disease, I'll say, well, I'm not sure this medicine is working. Your life is progressing. Things are, getting very advanced. So let's just try decreasing the dose a little bit and see if there's any change. Decrease the dose a little bit. If there's no change, then maybe we'll decrease it a little bit more. But if things get worse, then we'll just increase it back. So that's typically what I do. Yeah, so that's all. Do you want to say anything about those drugs?
It might have been, I know for Namenda especially, we came up with an extended release formulation of it. And that might be what you're thinking of, just because it allows it to last all day long. You don't have to take multiple doses, and so it doesn't wear off. That might be what that was.
I'd like to also say just one more thing about the disease. Since I lived with it for a long time, from normality to the end, it's not the same in everybody. It's almost like everybody has their own version. But there are some things that you can start seeing. We noticed that all of a sudden in her normal walking, for no reason at all, she would just, on an occasion, do a face plant. Boom, right straight down. Trying to increase her exercise, she would say something, well, you've been gone a long time on your bike, so I bought her a bike. Thinking she could ride to the park with me and we could do that. Well, we found out she could no longer ride a bike. Didn't have any idea that that would be that way, but it was that way. One day down in Florida, things that you've always been able to do and you don't suspect anything is going to happen. We were at a shopping center and we walked up to an escalator and she just stopped. From that day on, she could not get on an escalator. We had to take elevators. Just strangeness. And occasionally it got worse and worse and worse. And at the end, she went the whole cycle. They kept her happy. And she finally went into a coma and went to sleep.
That's how I like to go. The longest living Alzheimer's patient I've ever taken care of from time of diagnosis to time of death is 21 years. The average is somewhere between 6 to 10 years, or 6 to 12. But you're right, absolutely right. It presents and progresses differently in folks. You know, it's just, and what that really suggests is, like with many diseases, it may be that Alzheimer's disease is not one disease, but it's several different diseases. We don't know enough yet to be able to differentiate them, and we're just calling it all Alzheimer's disease, and that may be the case.
From the time she was diagnosed with MS, which we know is wrong, till the time that she went into the nursing home willingly, because she knew what was going on, it was almost maybe 10 or 11 years. And then another 6.
Sorry, can you hear me? I just turned it on. Can you hear me?
Can you hear me?
All right, well, we are at time, and I think we all want to say thank you from the bottom of our hearts. Thank you so much for the questions, for the candidness, for your stories, for the emotions. That's why we're here. That's why we started this, and we hope to come back soon. And certainly if you have any additional questions, as Lisa mentioned, July 7th, we'll be holding another panel at the Institute of Gerontology, Hudson Hall. And you can email carecenter@uga.edu. And we are here to care for you. Thank you, everyone.
Awesome.